All right. Hey, everyone. Thanks for coming in. Good to see you. Good to see you all out there. We're going to just it's 3:32, but we're going to give it a minute as people kind of still filter in. Not sure what read stop is, Todd.
I don't know why. I'm on a brand new computer, so everything is new. I don't know why it added.
Okay.
Trying to stop the meeting, though. That's all.
Yeah, if you could all just make sure you're muted, please. I'm just going to mute some folks here. All right. We're going to just keep everyone on mute because we do have a lot of people here today, just to be helpful for the speakers. All right. Well, welcome in. Good afternoon, everyone. Happy December. I hope everyone had a great Thanksgiving. Welcome to Prostate Cancer in 2025, Screening, Treatment, and Perspectives from Patients. I'm Trevor Maxwell. I'm a stage 4 colon cancer patient. I'm the founder of Man Up to Cancer. And today we're going to be talking about prostate cancer. Um, we have an incredible panel lined up. Just real quick about Man Up to Cancer. If you don't know Man Up to Cancer and what we do, we are a nonprofit organization. We inspire men to connect and avoid isolation during cancer. And we're grateful to partner on this webinar with the amazing folks at Johnson & Johnson. J&J has been a leader in the prostate cancer space for several years, well over a decade, with groundbreaking therapeutics and a strong commitment to empowering patients through education and advocacy. So very excited for that. And we have an incredible lineup. So let's just introduce our 3 panelists for today. We have Dr. Mahadi Baig. He is Vice President and Head of Solid Tumors for U.S. Medical Affairs at Johnson & Johnson. Hello to Dr. Baig. Secondly, we have Don Helgeson. Don lives on Vancouver Island, British Columbia. He is a prostate cancer survivor, and he is Director of Chapters and Meetups at Man Up to Cancer. And then lastly, but of course not least, is our friend Bob Lane. Bob Lane lives in South Carolina. Bob is a metastatic prostate cancer survivor and an incredible patient advocate. So these are going to be your 3 experts for today. And we're going to explore the prostate cancer landscape. So if you have never had prostate cancer and you're learning about it, we're going to learn about how to screen for it, what the guidance is. And if you are a prostate cancer patient or someone who's caregiving for a prostate cancer patient or survivor, we're going to learn about the lived experience of Bob and Don and sort of what they've gone through in their years living with prostate cancer. So as we move through this hour, please type any questions that you have. If I could ask you to please stay on mute and type any questions that you have in the chat. We're going to have about 10 minutes toward the end of the hour to answer any questions you might have. And if we can't get them answered, we will try to connect you after the show. All right. We're going to hop right in. And I will say it's December. Today's December 1st. Happy holiday season. It is a season of hope. And as Don and Bob and Dr. Baig will show you today, there is so much happening in prostate cancer, in the treatment and living with the disease. There's a lot of hope this season around prostate cancer. So I'm glad you're with us. So Don and Bob, thank you both for being here. You have each lived with this disease. You've turned your experiences into advocacy and serving others. So let's start at the beginning. Diagnosis. Don, can you tell us about your diagnosis story? How did you find out that you had prostate cancer? Did you have symptoms? And what were those early days like? We got to try to unmute Don.
There we go.
Hey,
I was panicking for a second there. I was trying to unmute myself, but
we got you.
Yeah, thanks everyone for having me here today. And so my story goes back quite a few years. I'm a Lynch syndrome patient, similar to what you are, Trevor, and I've had multiple cancers in my lifetime. And I was a guy who should have been looking for cancer, but didn't know that prostate cancer was something that was on the horizon for me. And in 2019, I was a police officer in Canada, and I broke my ankle making an arrest on a person, and it ultimately led to my early retirement from the force. And I had one last medical before retirement. And fortunately for me, I was over the age of 50 at that time. And my GP, my general practitioner, ticked PSA for a test that I should have with my basic labs, and my PSA was very, very high. And so from there, it started. The next 3 months was pretty much chaos in my life. But within a short period of time, it was confirmed that I had stage 3B prostate cancer. But I look back on it now, an incident that ended my career basically saved my life in some ways.
Wow. So yeah, you had an occasion to interact with a medical team that found this out for you. So if not, was PSA even on your radar screen at that point?
I didn't even know what PSA was, and I had some family history that I was somewhat aware of. I had an uncle who had passed away from prostate cancer uh, not long before this, and but I actually thought he had pancreatic cancer. I didn't know anything about prostate cancer, so I had zero symptoms. And if you're talking about symptoms, other than having a broken ankle and going through the things that go with that, I had nothing. And I thought, maybe some urinary issues, but I was thinking that as a 50-year-old man, that was normal. And it wasn't totally abnormal, but it was ultimately the PSA that started the ball rolling for me.
And if you could just focus in on, so there was a lot coming at you. You were 51, right?
Yeah.
And all of a sudden you were facing prostate cancer. Talk about just the emotional piece of it for you. How did it hit on the emotional side?
Well, first of all, I was by myself when I found out, when I had gone to do my basic labs, getting ready for retirement. And when I went into the portal that afternoon to see what the results were, I was actually more concerned about my cholesterol level. And there was this warning on there about PSA. And so I went to, Dr. Google, and sure enough, I had a PSA of 12.2. It should have been under 3.5.
Hmm.
And so I looked at that. I did Google, and what does it tell you? Most likely you have prostate cancer. So I waited patiently for a couple of hours for my wife to get home from work. But in the meantime, I was like, I started to panic, because everything I was reading about prostate cancer, especially as a younger guy, I was newly married within a few years. I was worried that my life was going to change drastically. And so, fortunately for me, and you know this, Trevor, I was already a member of Man Up to Cancer because of my previous two cancers that I had in my lifetime. I had immediately had some spaces to go to and reach out to some people. So, and I know we'll talk more about that in a bit.
Well, that is interesting because this wasn't your first primary cancer. So for you, you had heard those three words before, but this was another one on top of that. I mean, and who were your people supporting you, and sort of did you isolate at that point, or were you kind of used to already reaching out?
I was reaching out a bit with some people. I didn't have my leadership role within Man Up to Cancer hadn't started yet, but I knew a couple people in the group and felt comfortable enough to actually post in the group what I was facing, and immediately, and this was the power of the organization. Immediately, a couple of men who were younger reached out to me, and so I was starting over the next few weeks. Once it was confirmed it was prostate cancer, I had treatment options to decide upon. I wanted to know what the side effects might be, all of those types of things. But to try to find, I could easily find a 75, 80-year-old man locally to talk to. In fact, I got invited to a prostate cancer meeting where everybody was the same age as my father. So I was looking for a space to be able to reach out to people that were more my age to try to find answers to the questions I had that would be more specific to me. And so but I did reach out. I had a close friend living out on the east coast of the east coast of Canada. I just texted him that same day and just said I got this going on, and he calmed me down. But really, when it comes right down to it, I have an incredible family, and this I know my parents are on the call here too. My mom, who's a previous cancer survivor as well, like we just kept in touch. I had the support from them, my wife, my close friends, but ultimately, what really set me at ease was the ability to go into our organization at Man Up to Cancer. And I had two men specifically who helped guide me with not telling me what treatments to take, but what they did and why they did it. And that really helped.
Yeah, I mean, and Hello to the Helgesons. So, Helgeson parents, we love you. We've known you for a while. You're the best. Let's move over to our friend Bob down there in South Carolina. So, Bob, same question. Tell us about your diagnosis. What led up to it. And I think I've heard from you say before that you had no symptoms.
That's correct. And thank you again, Trevor, and thank you everybody for having me on board here. I've actually been diagnosed twice, no symptoms either time. Very simple, and that's not uncommon. Most men do not have symptoms when they present with prostate cancer. And if you do have symptoms, it's typically not a good sign because it's probably pretty far advanced. Uh, but I found out quite by accident with my GP, who was treating me for diverticulitis. He ran a PSA test and said, "Oh, by the way, your PSA is 7.5, probably a mistake because only 4 months ago it was 1.3.
Hmm.
So it's probably a mistake, but go get it checked out." So I did get it checked out at the urologist office. 2 weeks later, it was 10.5. They said it's not a mistake. They did some other tests, did a biopsy, and all 12 core samples were full of cancer. So they took it out surgically because of how aggressive it was. No real options for me, which again is uncommon. More often than not, people have the options of radiation or possibly chemotherapy or surgery. So no options. All the margins were clear in 2014 of July, and that's how it stayed. And they said, hey, it's 50-50 that it's going to come back. But right now, there's nothing there. So you may never have it come back again. So that's how I was living for 3 years. Every 90 days, though, getting tested, as I'll do for the rest of my life because of how aggressive it was. Until 2017, the middle of 2017, zero point zero 0.01, 3 months later, 0.03, 3 months later, 0.06. So for 4 years, we watched it grow very gradually because the technology for knowing that it was in there was better than the technology for knowing where it was. So we had to wait and wait and wait, and then finally it took off like a rocket again in 2021 June, and they found it in my C1 vertebrae, right between my brain and my spinal cord. So it's not operable, and it was growing like wildfire, either going to go one way or the other or both. And so they took it out with very, very intense radiation. So and now that was 4.5 years ago. I've been negligible ever since. So. Real short, if we're looking for a sound clip, the takeaway is, don't wait for symptoms. Go get tested, and start talking to your doctor in your 40s about getting tested. Because if you don't, if you wait for the symptoms, it could be a really short, really ugly ride. It's not going to
Yeah.
end well. So
Bob's not going to bury the lead here. Like, okay, he's going to jump to the chase. Like, let's get tested, guys. Talk to your doctor, right? And we're going to get into a lot of that. You had previously shared with me a story about you and your daughter, sort of like how you shared the news with your family. Can you share that here?
yeah, I found out in a car ride. I was going to a meeting 4 hours away from the house, and the call came in on my cell phone. I was 3 hours away from home, and the doctor told me the news. So I pulled over and cried like a baby for 20 minutes, and then called a friend of mine who's an anesthesiologist, and he talked me back to level a little bit and said, hey, we're going to get you in touch with the right doctor, blah, 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 which he did. So now I got to go down, finish my meeting, finish the other hour drive, have the meeting, drive 4 hours back home. And I was grilling out there outside of the screened-in porch, um, and trying to figure out how I'm going to broach this subject with my wife and with my children. And my daughter piped up and said, "Hey, Dad, have you gotten the results of your test back?" So real quickly through my mind, I'm thinking, well, do I want to lie to her? No, I don't want to do that. I better tell her the truth. So I said, yeah, I did, hoping that she wasn't going to ask me what they were. Like, big fat chance of that. She asked me if I got the results back. I think she's going to want to know. She's a college senior. She said, so what was it? Was it good? And I said, no, no, it wasn't good. She goes, well, how bad was it? I said, it was pretty bad. Oh, so that's how I broached it with her. And I asked her not to share the news with my wife because I wanted to have the conversation with her privately. So that's sort of how it came out, just because I felt like telling her the truth when she asked the question.
And just as I start seeing questions come into the chat, we are going to save all of those for 10 minutes toward the end. So please put them in there and we will get to you. So Bob, the emotions. Let's focus on the emotions of that early period for you. What was it like? How much did you maybe keep inside or share with others? Or, what was your emotional health at that point?
The emotions, I shared everything with my family, very wide open about it, and with everybody at work. I first talked to my boss. I said, "Hey, I would like to share this with everybody one-on-one, because I didn't want them to see me going through crazy bits of moodiness or whatever it might happen. I didn't know what was coming down the road. Uh, so we did that, and all the close friends and things like that. And I really didn't worry about it because everything, the margins were clean, and the test was coming back negligible. So I said, hey, I might be on a forever ride where nothing comes back and everything's good. So the only time I worried about it a lot was during the 90-day tests, the week leading up to it, and then the week afterwards, waiting for the results to come in. And if the results didn't come in for 2, 3, or 4 days, I'd start to worry that, oh, maybe the results are bad and they're rerunning them. So, the mind plays crazy games with you at that point. So I started to get a little bit itchy on those instances. But other than that 2-week window around the 90-day tests, everything was fine and clean until it came back the second time.
Yep.
And then we watched it for 4 years, and that was a very, very awkward 4 years, just knowing that the darn stuff was back in there, knowing that it was going to be aggressive at some point, but not knowing where or when. So,
What about specific fears, around mortality or, quality of life? Things like even, I guess, like toward the beginning, did you have any specific fears?
yeah, for sure. In the very beginning, I felt like it was over, and this was my swan song, and I was going to be gone. The care team walked me off of that ledge very quickly,
Mm.
really within a matter of a day of my first diagnosis, because I met with the doctor the next day. He made time for me at the end of his schedule. So that was the beginning of a wonderful relationship that continues to this day. He's retired, and we still have lunch 4 times a year. I'm going to have lunch with him on Friday. So, uh, so they were able to talk me right off that ledge, saying, "Hey, this is the golden age of prostate cancer. That we have things available, et cetera, no matter what happens when we do the surgery." So that was a good feeling. So I felt pretty good with the people around me, particularly with the care team, the nurses, doctors, and the radiologists ultimately when it came back a second time. So felt really supported, and they were able to give me all the information I needed. I did also they referred me to one patient, another prostate cancer patient from earlier years, years earlier, who went a completely different path than I did. He went the complete radiation path. So it wasn't a lot of hands-on help from what he's experienced to what I was going to experience, but still it was good knowing somebody else, having a face-to-face conversation with someone made a big, big difference for me.
Oh
So
yeah, I mean, and it sounds like you hit the jackpot when it came to your medical team and those around you to just say, "Hey, we got you. This is the golden age for prostate cancer. We're going to take care of you." In my experience working, talking with hundreds of men over the past several years who get a diagnosis, whether it's prostate cancer or any cancer, not everyone has that experience, right? Some of them, it takes a long time for them to find a team that they feel comfortable with or encouraged by. So I think it's great that your team it seems like they got you pretty well adjusted pretty quickly.
yeah, they got their arms around me very well and very appropriately, and it's been a wonderful relationship I'm in my 12th year and still with the same team.
Well, let's focus on decision making for a little bit. Patients, we are inundated with information at the beginning of a diagnosis. I call it the drinking from the fire hose of information stage. Um, so let's go to Dawn. How did you learn about your disease in the beginning? There's healthcare providers, other patients, internet, like there's lots of ways that you can find out about your disease these days. How did you find out about your disease, Dawn?
Yeah, and I just want to clarify too, when you asked earlier about the emotional side of things, I did freak out. I just want to make that clear that it was a hard couple of weeks to start with,
Yeah.
but then that ties into your question because I'm willing to do the research, and being a previous cancer patient, my medical team took everything very seriously. So I had after the high PSA reading, I was in to see my urologist within a week. I was able to talk with him about treatment options, especially as a younger guy. But I did. I relied on the internet a lot, and I learned right away that there was actually a prostate center on Vancouver Island where I live, and a health nurse who was made available to any patient where I live for free to go over those types of things. So immediately I wanted to talk about the different treatment options. As I was mentioning earlier, it was very much complicated by my age, especially when we're talking about going directly to surgery, which is ultimately what I chose to do. And being younger, and my wife being 7 years younger than me as well, that was a part of my emotions from the beginning was, how is this going to impact my marriage? How is it going to impact me and the rest of the people all around me? But ultimately, my marriage, could that fall apart? And I mean, those are all questions that now I look back on and I understand why I was thinking that. But
Yeah.
And so when I talk about relying on, I also talked to as many people as I could. And I even did the people that were 75 years old that were willing to share, I still accepted that. But being able to talk to younger men was really important to me. And I did. And learned that I was going to have to figure out my new normal. And I was willing to do that. I was willing to do whatever it took to get through this.
Yeah. Awesome. Appreciate that. So you actually did have a somewhat of a menu of options at that point.
Yeah.
Can you tell us what those were, like, generally?
Yeah, generally. So active surveillance, where they do nothing and just see how long your PSA continues to rise. And and I know Bob alluded to it as well. I had my PSA done, retaken 3 weeks later, just to see if it was an anomaly, and it had risen from 12.2 to 14.6 in 3 weeks. It was on the upswing, and but I didn't have a comparable. I'd never had a PSA test prior to that. But yeah, it was definitely, as far as I knew right away with my medical team that I had to make some decisions right away. And so they said, okay, radiation is on the table. We can put you in touch with the radiation oncologist. Now, add to the mix, this was in late 2020, early 2021. COVID was in the mix. There was no guarantees. I was going to have to go to Vancouver across a ferry ride to talk to a radiation oncologist. There was no timeline for that. But my urologist was actually my surgeon, and he told me that as soon as I said yes to surgery, that I could have surgery within a month or so of that. So, but really, when it came down to, in my scenario, was active surveillance, which was a no, radiation and surgery. We didn't know at that time whether hormone therapy would be in the mix, and so my homework during Christmas of 2020 was to make a decision by January 6th of whether I wanted to go through with the surgery or continue with a consult with radiation oncologist. And ultimately, I chose after speaking with radiation as well. I chose surgery, and I had surgery the third week of January of 2021.
And I got to get to Bob, and then we got to move to a different section. But where are you at now with your health? I know you had a relapse in the spring, summer in 2024.
Yes. Yeah, really, really quickly, my margins were considered clear. However, I did have some spread to the seminal vesicles, and so I was high risk for recurrence. And my PSA was undetectable up until mid 2023, and then we monitored it for about 1 full year, and it kept doubling every 3 months. And so we knew that it was back, and I chose to do radiation. And I ended up having 20 sessions of radiation to the prostate bed. And I also went on 6 months of hormone therapy. So 3 months kind of prior to the radiation, and then the 3 months after. And then the idea was that if my PSA was back to undetectable after the radiation, that they would stop the hormone therapy, which is exactly what happened. And I am now I'm about closing in on 18 months post-radiation, and I've had 6 straight undetectable PSAs.
Give it up for Dawn. Let's go. That's so awesome,
really,
man.
I think textbook is what you would say for that type of scenario. And so, yeah.
Goosebumps,
so now it's just exactly what Bob said. It's I'm due for my next PSA in 2 weeks, and so then the scanxiety starts. And but I'll take where I'm at. And you, my friend, told me one day, a long time ago, it's the best case scenario for what's been thrown at you. And so I'll take.
Well, I'm so proud of you, man. Thank you. Bob, same question to you. And I know we've talked a little bit about this before, where you didn't really have a menu of options like Don did. Explain what that was like for you.
I didn't have any, so I didn't know any differently. And it was just okay. It's real aggressive each time. The only option the first time was surgery. The only option the second time was radiation.
Yep.
So and intense radiation. 5 days worth. So
And
and it was fun. It was
did you rely on your team to inform you about everything going on in terms of how to treat this, or did you get information
yes.
from other sources?
No, it was through the team. I had vetted them out through a contact I had at Sloan Kettering, so they were the right people to be handling me. So they had a good, I had a good second opinion. But yeah, we just went with what they were saying. And the first time it was just, slam bam, and then the second time we had 4 years to prepare for what was going to happen. We knew it was going to manifest itself at some point. We just didn't know where or when. So we had already discussed any option that might be on the table when it found out that it was in C1, which they'd never seen in C1 before. But hey, I should play the lottery. But that's where it was. So the only option was radiation.
And tell us where you're at now, in terms of your health and your treatment.
Health and treatment right now, I'm on what they call ADT, androgen deprivation therapy, which takes all the testosterone, or most of the testosterone out of the body. There's still some other from the adrenal glands. And I'm living a great life. I mean, people tell me a lot of times, well, they're sorry for my diagnosis. I say, you know what? There's 8 billion people on the planet, and over 7 billion would trade places with me in a heartbeat. I'm enjoying life. I play golf. I walk and carry. Life is pretty good. I happen to have, prostate cancer I'm dealing with. So what?
Celebration for Bob at this point, everyone. That's awesome. Way to go. I mean, metastatic to the bone, and now just living your life, your best life, man. That is inspiring. I have
Thank you.
so many other questions for you. I do want to hit on Don real quick, and then we got to get over to our amazing expert, Dr. Baig. But Don, we've been kind of moving around this issue of ADT, and you talking about your marriage and your wife. I mean, really, when we're talking about losing your testosterone and having surgery and the potential of never having sexual function again, this is, for a man, this is a big deal, right? And for your relationships. And we're here saying that out loud and talking about it and saying, like, I'm thinking about my erectile health and my, the part of me that I really is very important. So Don, talk to us a little bit about your fears for that and what the reality was and is.
Yeah, I mean, I faced 100% erectile dysfunction post surgery, and that lasted for well over a year. And I mean, I knew that was coming, but having a strong marriage and having the pieces in place, including the nurse through the prostate center, I knew that there was options available to me. But I also, because I had reached out so much in the cancer community, I had some other men share experiences with me, including, medication and just some other things that could be done, and in learning about intimacy in other ways. And what's really incredible about all this is, even with everything that's been thrown at me, including being on hormone therapy for 6 months and the radiation and the surgery, I have almost 100% function back. And I mean, we're 5 years out just about here now, but it's been a process, but that's where we're at. And so I'll just say one more quick thing. When I was sitting in the chair, when I was sitting in my chair in my living room after surgery and recovering with a catheter in 16 days, by the way, that was terrible. That was the worst part of it all. I just remember saying to myself, I think there's an opportunity to make a difference here with especially younger guys going through this. And this is why I share this story, and I'll talk about any part of it with anyone who will ask, because I don't want anybody else to be my age and not be able to have an opportunity to reach out. And so that's where, like, our space through Manifest Cancer and other groups that I'm in, I get sent, people talk to me, it's almost weekly or twice a week, or somebody will be sent to me to ask these questions. And so I just don't want anybody else to go through that type of thing that I went through.
Yeah, absolutely. And I'll just get on my quick soapbox and say, the tools that are out there, the resources that are out there to help you with your intimate relationships and your sexual health and functioning during prostate cancer are way ahead of what they even were 10 years ago. Urologists are on top of it, but they can't help you if you don't talk about it. So it's on us to talk about it as guys and to get the help we need because there is help out there. So thank you, Don. Um, we got to move to Dr. Mahadi Baig from Johnson and Johnson. Mahadi, thank you for your patience, and thanks for being here. You have a unique vantage point. You lead medical affairs for solid tumors at Johnson and Johnson, and you're closely connected to the patient community. I think if we just do a total reset here, let's just start with the big question that everyone wants to know. What is the overview of current screening recommendations for prostate cancer?
Sure. No, thank you, Trevor, for having me. To everybody, hello. Thanks for being here. Before I get to the scientific part of it, I do want to acknowledge how powerful this community is for us as scientists and clinicians. I'm a medical oncologist by background, treated patients for a number of years, but decided to go into the route of research, worked on multiple different um, drugs before I took this newer role 6 months ago. Um, but forums like this, patients like you are what actually drives us. And you may be thinking, oh, this is a small call with 20, 30 people on it. It's not significant, but trust me, voices like that actually are very powerful. We are listening. We want to be your partners in developing therapies of the future. And what you tell us is extremely critical. So I wanted to know that before I get started. So coming for recommendation, um, the prostate specific antigen, otherwise generally people call it PSA, it's substance made only in prostate. That's why it's so specific to diagnose prostate cancer. As prostate grows with cancerous growth, it produces a lot of it. So unfortunately, prostate hides in a place deep down in our pelvis, and like you heard from two patients, really doesn't cause symptoms. And if any symptoms at all, which is obstruction of urine, is usually attributed to benign prostatic hyperplasia, which is a benign condition. So most patients, unfortunately, go along a long way before they get diagnosed. So this screening is extremely critical um, to diagnose it early, to catch it early, if you will. In 2025, a lot of different societies give you different recommendation, but generally, if you want me to summarize, it is a very risk-based conversation with your clinicians. Generally, most scientific organizations, so the NCCN, AUA, all recommend approximately around 45 years of age for an average risk person. Average risk person is person who doesn't have any family members or doesn't have any genetic mutations, etc., such as BRCA. Those people need to get it at 45, and then based on the risk and what they find, you either do it annually, every 2 years, every 4 years, depending on the risk. So that is what most screening guidelines recommend. But it should be a very informed decision because you want to understand what you're signing up for, right? Uh, when I was in medical school, what was taught was every man, if lives long enough, will develop prostate cancer because it's just naturally how prostate grows and develops. So it is risk for all of us, all men. So everybody should get it, but it's a conversation when you want to have it, talk to the right experts, because anytime we do a test, there are risk of following it through, getting biopsies, making sure it's a true positive test, etc. So 45 is what I would say, but some men who are higher risk can start as early as 40 years.
Yeah, thank you so much for that. I mean, and let's talk a little bit about geography-based care. So I guess what I'm getting at is where should people go? What's the entry point when you want to have that conversation? Is it with your primary care physician? Is it with a
I think
specialist?
the best and the most easiest, you got to make it easy for people to get access to this screening test. And your primary care doctor is fully equipped to do this
Mhm.
test. They know how to address it. So I think to make it easy for a barrier, like everybody who goes to a regular physical at 45, you just tell your doctor, I heard about this PSA test. Do you think it's applicable to me? Can we get it done in a very, positive way? You want to stay ahead of. So that will be the easiest way to do, because getting to any other experts usually is a barrier for most people in the United States or Canada, right? A urologist or an oncologist would not just see you to do a test, but
Right.
most primary care physicians are actually very well trained to do this test and follow through.
Uh, so public service announcement, if you don't have a primary care physician and you're a man and right, average risk 40, 45, get one or go see, right, go to the clinic, like make an appointment. A lot of guys don't have that PCP connection. And that's oftentimes why they don't get screened properly. Um, what about race, family history, genetics? How do these factors influence decisions on when to have those conversations?
Big one, right? Like particularly men of African American descent have a much higher incidence, but in addition to incidence, for the reasons we fully don't understand yet, they tend to have a higher mortality, means they die at a much faster rate than other people. So those are considered higher risk race. Family history, like your brother or a father had a prostate cancer history, especially if somebody is diagnosed at a younger age, less than 65, kind of tells you underlying that there's some genetic risk you're carrying. Maybe you want to look for those things, and some of those we can talk in a minute. And those generally are like BRCA mutations, which is BRCA2, which is the most common one, then BRCA1, something called ATM gene, CHEK2. There are many different genes which nowadays it's easy to check for those things with genetic testing. And that's what's most beautiful part about 2025 is our understanding of prostate cancer has gone so well, and precision targeting of these targets has evolved so well, and people understand this, what is driving these mutations, and if especially if those are present, it's good to target those, and there are effective therapies available for BRCA2 especially. So that's what we have to do. Like family history absolutely put you at a higher risk if you have those genes raised. Overall, when you look at yourself, you always have to ask the question, am I regular risk, or do I call family members, ask for certain history that put me at a higher risk, right? If like Don, in your case, I don't know if you've dug in through later, but I'm sure if you go deep enough, you'll find some pattern where you can actually see those things.
Yeah, and I hope that everyone had those awkward Thanksgiving table conversations about, prostate cancer in the family and colorectal cancer and all the cancers because, when the family's all together, that's when to gather that info. Um, Early detection, Mahadi, how important is early detection for survival in prostate cancer?
Oh, it's absolutely uh, the cornerstone of improving survival is early detection. And that's why when you have an effective test like PSA, you got to check it. It takes one blood draw. Probably you can do it in the same blood draw you got your cholesterol test in. It's as simple as that, right? So it is the same needle. You don't need to get an additional. So it's cornerstone because 100% of patients who have localized prostate cancer um, are alive at 5 years, right?
Wow,
That's a powerful statistics to know and understand, and a driver for each one of us men to go up and ask for the PSA test at the right time. Um,
that's incredible. 100%.
yep,
So,
it's
and
localized.
and unfortunately, the body's just not throwing out red flags to say, "Hey, it's time to go get tested for this," which is why it's critical to have these
Yeah,
conversations.
Yeah,
gotta be up here. Yeah.
Um, so we've talked a lot about right screening. Once you get prostate cancer, let's talk about treatment. What does the treatment landscape look like in 2025? It seems to be rapidly evolving. Can you walk us through today's key approaches in treatment?
yeah, absolutely. In any clinician's mind, you divide cancer into two big buckets, if you will. One is localized prostate cancer, means your prostate cancer is well controlled. We are able to deal with it and it has not spread to the other parts of the body, right? If it's localized and within prostate, the best, you can do active surveillance, because if it's very low risk, and if you're 90, 95 years of old and you want to watch it slowly over the next year or two, that's a perfectly right answer. But for most patients, radical prostatectomy, which is removing the prostate gland, is probably the standard of care option at this point, right? And nowadays there are many approaches which are more robotic, etc., which spare your nerve, etc. So the outcomes are much, much better. It's not used to be what in the back in the day. And for patients who are not eligible for study or cannot get surgery, there are other forms of treatment such as radiation therapy, which could be both focal ablation as well as external beam radiation. So even radiation, there are many different variations. We won't get into that here, but suffice to say that, if you can either get surgery, radiation, or for some patients, a small number of patients, in a specific cases, just following the PESA may be also the right answer. And when you actually become metastatic, which is the cancer goes beyond the prostate gland and other parts of the body, you have two broad categories, which is what we call metastatic hormone sensitive, means your prostate cancer is driven by the hormone androgen, right? So if you're sensitive to that, you can just block it. And the cornerstone of that particular group of cancer is called ADT therapy, which is androgen deprivation therapy. You give drugs to block the pathway which drives the androgen pathway and grows the cell. And that usually helps patients. And once you pass that state and you become something called metastatic castrate resistance, means you're not anymore sensitive to these hormones. You need other types of therapies. For those patients, we generally tend to give um, something called androgen receptor pathway inhibitors, ARPIs, and I'm not taking any specific names of the drug just to be objective and impartial. And then we can give chemotherapy or some newer drugs for patients who have BRCA mutations called PARP inhibitors, which specifically only target that mutation. And all of us have heard about the development of immunotherapy for a very small group of patients who have something called microsatellite instability high, which you can check through biopsy. Pembrolizumab, which is an immune checkpoint inhibitor, can actually help. So those are the modalities today available for patients. There are other newer ones which are very exciting. I always tell people why we are living in an era in the last 5, 10 years that there's been more explosion of therapies and our understanding of different types of cancer, especially prostate cancer, which has not done but in the total of last entire 100 years, right? So much more data is available today, and I think it's only going to get better with advent of artificial intelligence, etc. The speed at which we can understand biologies, etc., are really, really accelerating fast. Some of the very newer modalities of therapy, or something I'm sure you'll often call PSMA, which is uh, the drug which is very commonly used is lutetium-177. These drugs actually radioligand therapy. They target to prostate specific antigen and provide local radiation to ablate the tumor, which is very um, highly specific type of low radiation given systemically. Then you have something called alpha emitters, and more recently there are some bispecific. There are also targeted anti-drug antibody conjugates, and also cellular therapies such as CAR T cell is being explored. These are all newer, which is going to be available 25 onwards in clinical trials, and hopefully some of these drugs, if show benefit in clinical trials, can move on to being available for patients in the market.
So my caveman layperson perspective is you have a drug that is seeking out a certain target, like a biomarker, and with the drug, it has like a smart bomb attached to it. So you're doing, you're smart bombing rather than carpet bombing, right?
Carpet bombing, yes, absolutely.
And that's what we want to do across all cancers is be more precise because the systemic therapies that target throughout the body are the ones that often really hurt quality of life,
And believe it or
suffering.
not, the precision medicine you're talking about, ADT is actually one of the first precision medicine. It directly targets the androgen receptor. It is, specifically targeting what drives the cancer. It's one of the very early precision medicine drugs. People don't see it that way, but it is actually one of the precision medicine drugs.
Right.
Yeah.
When did that start to be used in therapy?
Oh, almost 2 decades now. Yeah.
And what's most exciting for you? If you had to pick one in terms of an emerging therapy or what's happening in 2025, what gets you most excited?
Um, we have bispecific drugs, means the drugs act on two separate specific targets. So in the past, we used to do like precision medicine means you want target with one drug, one particular target. Now we have drugs actually targeting two at the same time. You're actually, with one dose of a drug, you're getting twice the money in return. I think those are actually going to be extremely exciting in the next year. ADCs are next, are coming up in prostate cancer really good. So these are the things which are really going to drive the next wave of innovation in prostate cancer.
We are going to move on to some questions, but I just want to say for you, Dr. Baig, thank you for such a clear and really a hopeful overview of prostate cancer screening and treatment in 2025. And as a patient community, we appreciate partnering with Johnson & Johnson and bringing this stuff to our community and to the public. And we just appreciate your work. So thanks for being here.
Oh, thank you.
And then I wanted to say let's circle back with Don and Bob and then we can answer some questions. But I really wanted to get into some advice for the newly diagnosed. So Don, let's start with you. Imagine you're sitting with a man. He just got a prostate cancer diagnosis. Are there certain pieces of guidance you want to make sure that he knows?
I would say number one, you do not have to go through this alone. There are many, many options, whether it's groups like Man Up to Cancer, whether it's being willing to reach out and share with your friends and family. They're there to support you. Just, I would say trying to do this on your own is you're just going to be creating more of a mental health storm, I guess I would say.
Yeah.
The fact that I was open right from the very beginning, I know is why things were a lot easier for me.
Thanks, Don. Bob, same question. Anything that you would tell that newly diagnosed man sitting next to you? And we know that you do this a lot. So we're pulling up Bob's bio right here, and I would just add, so he's known in sort of North Carolina, South Carolina as Elevator Bob. Actually, Bob, you're better at explaining that. Tell people how that came to be, if you could.
Sure. Let me first get the other answer, and then before
Yeah.
I can tag on to what Don said.
Yeah.
Yeah, I would echo that you're not alone. There's countless reasons. This is the season of hope, but there's countless reasons, as the doctor just outlined. I mean, there's just 37 things that he just talked about that are positive. Build yourself a support team. I'd like to say three-legged. Your care team, your family, and fellow prostate cancer patients. And it's easy to do now. It wasn't easy for me because they didn't exist as much back then, but it's easy now. Ask questions of your care team, and don't look back. Look forward. I say paraphrase Morgan Freeman in Shawshank Redemption. Get busy. Don't get busy dying. Get busy living.
Right on.
Yes.
So I would say that Elevator Bob, my head nurse came to me one day and said, "Don't you think it'd be nice if the patients coming out of here on the advanced clinic days had someone to speak with who's been through it?" I said that would be really nice. And then 12 seconds later, she asked me the same question. I said, "You're apparently not asking my opinion." And she said, "No." So I do that twice a week. I sit out there in the elevator lobby, hence the term Elevator Bob. And I don't approach any patients because nobody who just learned to have prostate cancer wants to hear from some stranger. But they come up with creative ways. I wear a shirt that says Elevator Bob. I have a mug that says Elevator Bob. They hand out pieces of paper inside the office. It says, "Go see our friend Bob. He's a prostate cancer survivor, stage 4, blah, blah, blah." So we try and make it easy for them to approach me. And once they do, I will offer them compassion. I offer them hope. Let them know they're not alone. Offer them information if they'll share their email with me, that a person-to-person specific email based on what their diagnosis is, whatever they can share with me. I'll give them information. I won't give them a recommendation. I don't recommend anything. I'm not a doctor. But I will give them information that they can ask the doctor enough questions so they can chart their own journey. And that's what I do 2 days a week.
Yeah, absolutely amazing. So folks, if you want to get in touch with Bob Lane, take a screenshot, jot down his information here. And then if we could go back, Hope, if you want to pull down the slides while we do the questions, we'll come back to this one. Yep. And I had asked my friend Marissa to monitor the chat, but I don't see a ton of questions, so I think I can handle these. Thank you though, Marissa. Frank wants to know, does treatment for other cancer affect PSA results? This is, let's see if Dr. Baig can answer this one.
Yeah, no, I'm happy to take it. I think generally the answer would be no, except that sometimes chemotherapy such as docetaxel, etc., which can be used for other cancers, if used for treating some other cancer, can maybe artificially lower the numbers a little bit. It's a very nuanced question. I won't say 100% of the time it's not affected, but most treatments are organ specific except for chemotherapy. So if you're using chemotherapy such as docetaxel or other, which can actually work on even prostate cancer when you're trying to treat something else, it can hide it for a little bit. But for most part, it should not. But the levels will be elevated enough for you to just understand that there's something going on. So you should still get a test.
And a follow-up from Frank on the medical side. How effective is MRI or CT versus plugging for screening? I'm not sure I know the term plugging.
Plugging, um,
And Frank, maybe
Frank,
you want to hop, you can unmute yourself, or let me see if I can get you on.
chat. Yeah.
I think you should be able to hop in. Yeah, there you go, Frank. Go ahead.
When they put the gun up your butt and take physical sections.
Biopsy.
Okay.
Biopsy.
Biopsy. Yep.
I, so the I think MRI is still one of the most sensitive with the newer methodologies with PSMA, etc. It's a lot more sensitive to get an MRI. When we give you know do invasive procedure, it's usually more to localize for biopsy, etc. But yeah, MRI for most patients is a lot more sensitive for soft tissue than a CAT scan.
And this one,
versus the physical biopsy where they take sections.
So biopsy is so with imaging, you're just trying to diagnose. Biopsy, usually for most patients, you should be able to do a blind biopsy of prostate. Sometimes it's not possible if it's only one part of the prostate. In that time, you'll do an ultrasound through the rectum and try to get to that specific part, the problem part.
Now, the reason I asked this, there's 7 of us boys in the family, and the one that had cancer, he was like at a 4, and my other 2 cousins are like in the high 20s, mid 20s. I'm in the high teens, and my brother's like 9. But we've all tested negative when we've tested. But I'm sure at some point in time, I'm 65, that negative could turn to a positive.
This is just my personal opinion, not medical advice. But if your prostate PSA is high, I will keep looking. The best way to do is do a rectal ultrasound or a rectal like invasive imaging, and then try to find that small nodule or specific part of the prostate which may be involved. Very rarely, a benign prostatic hyperplasia can have slightly elevated, but it shouldn't be anything above 10 makes me nervous. And my family members all the time call me with those numbers when they have screening. So I would keep looking and try to. And again, there's another way of looking at it is if you do serial PSAs every 3 to 6 months, and if it's not really going up very fast, that means you have more time to look for it. Let's say if your number stays 10 over the 6 month period and again 10, maybe you don't have to worry as much as if it goes from 10 to 11 to 12, right? So that's called PSA velocity. I would check with your doctor to continue to do very frequent PSAs to check for the upswing if there is.
thanks, Frank, and thanks, Dr. Baig. Todd has a question for Bob. Bob, did you have ADT on the second occurrence? And was that with radiation treatment?
Good question. Yes, I'm undergoing ADT, and it will be for as long as it's effective, for as long as it is sensitive, as the doctor spoke of earlier. At some point, it will probably not be sensitive anymore. That's the likelihood, but we could go 10, 15 years. There's no way to know how high up is. But yes, I started on that right after the radiation, and I'm still on it every day.
And this is for Bob and Don. This comes from John, who is a member of the super high performing main chapter of Man Up to Cancer. Maybe would be considered a leading, the leading chapter. I don't know. John wants to know, have either of you had bone density scans? He is 18 months into ADT and has osteopenia.
I've had two, but none since I was on hormone therapy or ADT, but I was only on ADT for 6 months, so I haven't had one scheduled since. But I think Bob probably has more to say on
Yeah,
that.
yeah. I had my first one done as soon as the radiation started, or as soon as it ended, within a couple of weeks, and have one about every 3 years since then. I'm also on another drug, Prolia is the name of the drug I'm on, with a bone density to augment the density because of the deterioration that takes place from the other two ADT medicines. So yes, it is something to be aware of, and the more you can manage it and the more you can monitor it, the better off you're going to be down the road.
Dr. Baig, did you want to add on that with the osteopenia component?
Yeah, I think there are measures to minimize, like Bob said, loss of bone density, and it's an individual conversation where you started, what is the baseline risk, etc. So depending on, it's definitely helpful to be on those preventive medications to prevent bone loss for sure. Yes.
Frank also followed up with a question about how typical is it for prostate cancer to metastasize to the brain, Dr. Baig?
Fortunately, it's rare. This is one of the few cancers which doesn't go to brain. There are some which love to go to the brain. So yeah, it's maybe less than 1% even for metastatic patients. For early stage, it's almost non-existent risk for localized cancer.
And another question about PSA levels. Richard says, someone in another group I'm part of said your activity prior to testing can also affect PSA results, such as riding a bike or motorcycle can give a slightly higher result. Their recommendation is to give your body time to settle down between your activity and the test, or be consistent with your activity before you test. Is that actually true?
I no, so I, if any changes, even when you do a digital rectal exam to really examine the prostate when you check, sometimes it goes up a little, but not enough to put you in the range of being considered for a cancer diagnosis. So let's say normally you were 1 and you do something with even the digital rectal exam, it may go to 1.1, 1.2, not a whole lot. So that's a myth. And by riding a bike, you're not really stimulating or exerting your prostate. It really sits very well protected within your pelvic cavity.
Thank you. It's actually right on time. Could we hope if you could pull up the slide on the Blue Jacket fashion show? Before we wrap up, I just want to, Man Up to Cancer has a pretty amazing collaboration with Johnson & Johnson right now for this Blue Jacket fashion show. And I'm hoping, let me see if I can find Marissa. Let me see if I
Sorry,
can.
give me 1 second. I'm working on it.
Yep. So,
Hello, I've been released from mute
yeah,
jail. I'm here.
yeah,
I'm here.
yeah. So Hope is working on getting up the slide on the Blue Jacket fashion show, and then we'll talk a little bit about that, and then we're gonna wrap it up. I know that we're at 4:30, but this is a really cool project, so I'd love for you to hear about it. Yeah, Marissa, go ahead.
Absolutely. Yep. So the Blue Jacket fashion show is something super interesting that we have roped Trevor and Bob into walking the fabulous runway for. So this is really like the brainchild of a real life fashion designer, Frederick Anderson. Encourage you to look him up and see his fabulous designs. And he had a prostate cancer scare a couple years ago, and that was really enough to turn his attention to it and say, I want to do more about this. I want to raise awareness about this. So he does what's called the Blue Jacket Fashion Show, which is now a premier bi-coastal real fashion show event that he does. We just did the LA one in early November and have the New York one coming up in February. The New York one will mark the 10th anniversary of this. So it's really a unique first of its kind event where it brings together fashion, health awareness, advocacy organizations, the prostate cancer community, and celebrities. I'm like burying the lead here, of who gets to walk the runway and do media. And it really has phenomenal reach, in media and social media, all of the above. So J&J has just been so lucky to partner with Man Up to Cancer, to, just approach the show in new ways in our 10th year partnering on this, and to walk the runway, and really get the word out there. So we hope to have some other creative ideas in the pipeline coming up for the next show that we have. And excited to report and kind of share the early news that Don will be there, Trevor again, Bob, and this crew. So definitely stay tuned for more info. There's a live stream, and we look forward to sharing more, but definitely would love your engagement there.
Let's go, Dawn. Hope, can you bring that down again so we can just, oh, it's me. Hey there. So thank you, Marissa. I did walk the blue carpet in Los Angeles, but I'm so glad to pass that. I loved it. It was awesome, but I am glad to pass the torch to Don Helgeson, right here with us today, is going to be in New York City for Fashion Week. So if you happen to be around the Big Apple and you want to be part of that event, reach out because we'd love to have you there. It's really, really cool. Marissa, thanks again for amazing collaboration on the Blue Jacket Fashion Show. So as we wrap up, it is 4:33. We did pretty well. Two things. Number one, I have a challenge for you. Find 3 men in your life who should be talking to their primary care doctor or any doctor about whether it's the right time for them to screen for PSA. I want, this is a ripple effect. You folks that are here have learned about it, and it's one of 8 or one of 7 men will be impacted by prostate cancer. So please find 3 men in your life, have this conversation. It could save their life the way that Don, had that amazing, opportunity to find out about his disease. So please find 3 guys and pass it on that they should be talking to their doctor about screening. Man Up to Cancer. We want to take these conversations that weren't had a generation ago, the conversations that are hard to have, the ones that families need to be having, that everyone should be having around cancer screening, and bring them into the light. That requires really brave, awesome guys. So Don and Bob, I just want to say thank you for being those brave men and talking about your journeys. And Dr. Baig, thank you for your expertise. Thank you for your time today. Thanks for coming on and sharing this information that can save lives. And yeah, here's us. If you're interested in learning more, go to manuptocancer.org, and you can also become a member. Everything's always free. Take a snapshot of that, screenshot that, and the Wolfpack doors are always open. So hope we can bring it down, because then we'll just say we'll have a little goodbye. And if you have any questions that didn't get answered today, you can reach out to me, Trevor at manuptocancer.org, and I'll connect with Bob and Don and Dr. Baig and see if we can get them answered. So Trevor at manuptocancer.org if you have any other questions. Other than that, thanks for being here. Take care, everyone.